Welcome back, Rebel EM listeners, to another episode of Rebel Crit. I'm your host, Frank Lodeserto. And Eric, who do we have with us today?
Yeah, so we got Dr. Michael Bass again joining us today.
Thank you for having me again. I'm excited to be here.
And Eric, what are we talking about today?
We've been going through this approach to the critically ill patient. And so we've talked about hypoxemia, tachycardia, tachypnea. So now we are on to shock.
As Eric said, the approach to someone who is tachypnic, and we looked at their tidal volumes, someone who is hypoxemic, and someone who is tachycardic. Today, we're going to talk about shock. We're going to look at a simple algorithmic approach to shock. Mike, can you just define for the audience, what is shock?
Shock, simply put, is a supply versus demand mismatch, where if left unattended, could result in organ damage.
Absolutely, yeah. And we went to this DO2 equation, which is the cardiac output times the hemoglobin times the saturation plus 0.003 times the PaO2. And we're trying to optimize this in someone who potentially could be in shock to supply tissue oxygenation, so as Mike said, that they don't develop tissue hypoxemia or hypoxia and develop end organ damage. And this is the patient that you're called to the bedside who has a low blood pressure, but they seem fine, right? Have you guys been called about that?
Yeah, we were discussing before we started recording. You gave a lecture very similar to this last year during our intern year, and it has been probably one of the most helpful and rapid assessment of our patients where we get called by nursing and there's low blood pressure. And this really does help with differential and acute management of a patient, and it served us very well.
Good to hear that. Absolutely. We're going to get into that, but I want to make sure first you're called to the bedside. Someone has a low blood pressure, but you get there and they look pretty good. They look pretty good. So probably need to recycle that pressure, make sure the blood pressure cuff is the right size and it's put on the right location. Because the things that I look for, my quick 4 L's to decide if someone is truly sick, are the 4 L's are this. So you got low blood pressure. I look at the first L, are they lucid? What's their mental status like? Do they have enough cerebral perfusion to support good mentation? So I've been there and patients are trying to flip through the channels of the remote and they look completely fine. So they are lucid. I feel their limbs, make sure they have good perfusion to their extremities. I can look at the cap refill if it's delayed. I feel if they're warm or cold. The third L is a little bit of a stretch, but it's kind of a funny one. Are they taking a leak? That's the L. So are they peeing? What's their urine output been? They have adequate urine output. And the last one, if you are concerned, we can send off a lactate level as a warning sign that there may be some stress going on. So that's my 4 L's. This is just a patient who looks completely fine, does not look sick. That's my little mnemonic that I can use at the bedside. But let's talk about the patient we are concerned about. Regardless, and I should say this, that shock is not defined by a blood pressure. So you can have compensated shock where the blood pressure is preserved, but you're seeing some signs, as Mike was saying, of supply-demand mismatch. Eric, what does this patient look like? What are some of the symptoms that maybe describe the patient that we're going to talk about?
We're going to see some patients who are a little bit more tachypnic. The heart rate, respiratory rates are a little bit up. Now, the heart rate can be up in most cases. Just put an asterisk next to that. We'll talk about that later. Some of these patients are becoming to be a bit more confused. Altered is the other word we might use for it. Decreased urine output. If you touch those extremities, they're a little bit cool to the touch. If it's pretty extreme, you might see some molting. And then the capillary refill is a little bit delayed.
Definitely a sick patient. And I think we are going to focus on the blood pressure today. But like I said, I just want to emphasize that this may be a patient with a normal blood pressure, maybe even elevated. So we call that compensated shock. But let's focus right now on, we are called to the bedside. Patient's blood pressure is low, and they have some signs that they are in shock. So this is not the guy flipping through the TV remote. This guy is sick, or this gal's sick. So one of the things that I look at is the blood pressure, really. I'm focused in on the blood pressure. I'm looking specifically at 3 different parameters in the blood pressure. I'm looking at the systolic, the diastolic, and then the difference between those, which is the pulse pressure. So let's get into the systolic blood pressure first. I don't think I learned this in med school. Maybe you guys did where you went to school, but I didn't learn this little simple way to look at the systolic blood pressure. And that is what generates a systolic blood pressure. So whether you have an arterial line in an ICU, or you have a blood pressure cuff on, what is actually generating that systolic blood pressure? And that simply is the stroke volume. So as your heart is squeezing, that amount of blood that's coming out of the ventricle is called the stroke volume. And that stroke volume is actually generating the vast majority of our systolic blood pressure. Now, I said the vast majority of our systolic blood pressure because there is a component of aortic and arterial compliance, or the stiffness of the vessel. So the systolic blood pressure is measuring our stroke volume. All right, so that's the systolic blood pressure. And I want you to think of stroke volume here. And then we'll get into the determinants in just a second of stroke volume. The next blood pressure we ultimately look at is the diastolic blood pressure. So after the heart has squeezed out that volume of blood that we're calling stroke volume, and you have the systolic blood pressure, then you have to maintain end organ perfusion while the ventricles are filling back up with blood during diastole. And what determines the diastolic blood pressure is your systemic vascular resistance. And the third parameter is the pulse pressure. Let's talk a little bit about the pulse pressure. Mike, just for the audience, what is the pulse pressure?
Pulse pressure is just simply put the systolic blood pressure versus the diastolic pressure and the space between those two measurements.
Yeah, systolic minus the diastolic. So we can have a wide pulse pressure or a narrow pulse pressure. That's going to determine a lot of the causes of our shock. That pulse pressure is so important. And when I was an intern, I didn't look at that very well. So I want you guys to know what we're dealing with when we have a narrow pulse pressure or a wide pulse pressure. Just a couple notes here, though, I want to make is we tend to talk about the MAP, the mean arterial blood pressure, the MAP. And that is an important number. Many people ask me, where have we come up with this number 65, right? This magic number to keep the MAP 65. And it really comes from, and I'm going to put some links in the show notes, but there have been several studies, some anesthesia data, looking that if the MAP is less than 60 for even up to 5 minutes, it can cause some end organ dysfunction and damage to the kidneys, coronary vessels. So that's probably the magic critical perfusion number for the brain, the heart, the kidneys, around 60 to 65, depending on the individual. And there have been some trials looking at what is the magic number. So it looks like somewhere between 60, 65, especially when you don't know the patient very well. That study comes at the MAP 65 trial, and we'll put that in our show notes. But that's the magic number we're looking at. But I am looking at the MAP and what it is, but I'm going to focus in here on the pulse pressure because it's going to tell us the causes of, it's going to help us figure out the cause of our shock. But before I get into that, one of the things I do want to mention is the stroke volume and the determinants of it. That'll also help us figure out the causes of shock. So the three main determinants of stroke volume are preload, afterload, and contractility. That may ring some bells from medical school. You learned that somewhere along the lines. So again, the three determinants are preload, afterload, contractility are the determinants of stroke volume. And remember, the cardiac output is the stroke volume times the heart rate. So in many of these patients, you're going to see an elevated heart rate unless you've recently beta blocked them for some reason. But again, that heart rate is trying to go up and increase to increase oxygen delivery because you may have a decrease in stroke volume to increase our cardiac output. That's something under the control of the patient, increasing the heart rate. So again, that's why Eric had mentioned heart rate may be elevated in someone who is in shock. So let's look at and talk about the pulse pressure. Why does the pulse pressure narrow? Why does it get wide? When someone has a decrease in their stroke volume, so let's say it may be from a decrease in preload, a decrease in contractility, they have a low stroke volume, that leads to a low systolic blood pressure, the body's going to try to compensate to increase perfusion to tissues. It does so by increasing the systemic vascular resistance. One of the most important organs we're going to see is the adrenal glands. So there's going to be an increased release in cortisol, increased catecholamine release. That's going to increase our heart rate maybe even more and cause vasoconstriction. And as we said, diastolic blood pressure is determined by systemic vascular resistance. So to compensate, our patient is going to vasoconstrict. Now, if you have a patient already thinking about this, if you have someone in cardiogenic shock and you increase the systemic vascular resistance and the diastolic blood pressure, that's going to increase the afterload, making it even harder for someone to pump blood out of that ventricle. All right. So we have a patient trying to compensate. They have a low stroke volume. That might be because of low preload, low contractility. They have a low stroke volume, low systolic blood pressure. They're compensating by increasing the diastolic blood pressure and thus narrowing the pulse pressure.
That leads us into those three different categories of the narrow pulse pressure. So I'll just briefly do cardiogenic, hypovolemic, and then your obstructive shocks all fall into this narrow pulse pressure category.
That's right. We'll go through these one by one. In cardiogenic shock, what's the main problem? Main problem here is going to be a problem with contractility. So let's just go back, make sure everyone understands. Low contractility will lead to a low stroke volume. Low stroke volume will lead to a low systolic blood pressure. To compensate, our patient's going to increase their heart rate to increase cardiac output, but they're also, because of catecholamine release and cortisol release, going to increase their systemic vascular resistance, thus raising their diastolic blood pressure and then narrowing the pulse pressure. So at the bedside, someone in cardiogenic shock may have elevated heart rate, narrow pulse pressure. And if you do lay your hands, that's why we use that mnemonic with the L's, particularly you feel their limbs. Mike, what might their limbs feel like? And what are some of the signs that they might not be perfusing, just for the audience, so to follow with us?
So in cardiogenic shock, if you're going off of your 4Ls, the big thing is you may not feel their pulse as well. They may feel cold. You just won't have good tissue perfusion. But those are the big things that I normally have seen.
Absolutely. And one thing that we often don't do, and we do it more in pediatrics. I also am a pediatric intensivist. We constantly talk about the capillary refill. And there has been some data looking at capillary refill as a marker for perfusion and guiding resuscitation. And the study called the Andromeda trial showed that lactate as a marker for perfusion was as good as a capillary refill. So that's another important test. But as Mike said, we're going to have someone who's cold, decreased pulses, and a delayed capillary refill. And that's someone in cardiogenic shock we used to refer to as cold shock with a very narrow pulse pressure. So that's the first form of shock. Someone who is with narrow pulse pressure, they feel cold to touch. Now, what's the next one? What do you want to talk about next, Eric?
The next one would be this hypovolemic.
Sure.
That has two subcategories. You got your dehydrated patients and your hemorrhagic patients. And typically, I would say hemorrhagic external bleeds, but also internal bleeds. Dehydration has to be a kind of a prolonged period of time without fluids.
Sure. So again, their problem here is a decrease in preload. A decrease in preload, as we kind of trace this back, will lead to a decrease in stroke volume. A decrease in stroke volume may lead to a decrease in systolic blood pressure. The body will compensate by, again, increasing your heart rate to maintain cardiac output. But also, once again, just like cardiogenic, you're going to have an increased release of catecholamines, cortisol by the adrenal glands, and that will raise your systemic vascular resistance, thus raising your diastolic blood pressure and narrowing your pulse pressure. So once again, both of these categories are cold shock. So we have cardiogenic shock, which is a cold shock with a narrow pulse pressure, and hypovolemic shock looks very similar to that. Narrow pulse pressure, cold to touch, elevated heart rate for the most part. And then we have one more form that falls into this category of, let's just call this cold shock with a narrow pulse pressure. And this has multiple causes here. Just for the audience, Mike, what's this last cause? And can you just name the different causes of it?
So the last one of our narrow pulse pressure would be your obstructive shock. And that can be subdivided into your pneumothorax, specifically like your tension pneumothorax, your cardiac tamponade, and finally your pulmonary emboli.
Yeah, so you can look at this as some kind of obstruction. I look at it as an obstruction of preload. So going back and making this real simple, if we have maybe adequate preload, but obstruction of preload, functionally speaking, an obstruction of preload is going to lead to a decrease in stroke volume. That decrease in stroke volume is going to lead to a low systolic blood pressure and, again, a narrowed pulse pressure, like we just mentioned. So just taking these real simple, if I have a pneumothorax or there's air that's introduced into the pleura, that's going to increase my intrathoracic pressure. That rise in intrathoracic pressure is going to decrease my very compliant vessels, my IVC, my SVC, and there's going to be a decrease in preload coming back to the heart. So maybe preload is adequate, but it's obstructed. In tamponade, there's either blood or fluid building up in the pericardial space. That blood or fluid in the pericardial space is going to decrease filling, and that is also in the heart, and that's also going to lead to an obstruction of preload. And the last one is a pulmonary embolism. This is a obstruction somewhere in the pulmonary vasculature and maybe even a larger clot that's sitting in the pulmonary artery. Again, preload is okay, but that preload is going to cause an obstruction from the RV pumping blood to the left atria. Again, once again, a preload obstruction, which is going to decrease our stroke volume. That decrease in stroke volume is going to lead to a low systolic blood pressure and narrowing of the pulse pressure. So we covered cold shock. those patients that have a narrow pulse pressure, that's cardiogenic shock, hypovolemic shock, and obstructive shock. So now we walk up to the bedside, we see a patient who's hypotensive, we see a narrow pulse pressure, and now we have a better differential what's going on. All we need here is a little information, and we can probably hone in on what the problem is. Maybe it's someone with a GI bleed. We're noticing some blood on the bed, or they're having some elevated troponin levels, chest pain, maybe they're in cardiogenic shock, or something's going on that's leading us towards obstructive shock. Now, I think just with this knowledge of the pulse pressure, how the systolic and the diastolic are maintained or what causes these pressures to be generated, and that pulse pressure, just with a little bit of data from what's happening at the bedside, we're able to get a pretty good differential of what's happening.
That leads us over to this wide pulse pressure, where we have 5 or so different topics to go into and try to briefly cover here. This is, again, wide pulse pressure. We have septic, we have neurogenic, anaphylactic, and adrenal crisis, as well as hepatic failure.
Yeah, those are the 5 causes of this wide pulse pressure. We refer to this as distributive shock. So these 5 causes of distributive shock, always think sepsis, sepsis, sepsis. Sepsis by far is the most common cause of shock in the hospital. That was seen, and I'll put this in the show notes, by the SOAP-2 trial. But sepsis is probably our main cause of shock in the hospital, depending on where you're at, but the main cause. So always think sepsis, sepsis, sepsis when you have a wide pulse pressure. But there are other causes, and we refer to this as distributive shock. So the problem here is that the patients may have an adequate stroke volume, adequate systolic blood pressure, but the problem here is vasodilatation. So a decrease in systemic vascular resistance, and therefore a decrease in the diastolic blood pressure. And why do we call it distributive shock? It's basically a problem with vascular tone and how that blood is being distributed to the end organs. So we'll get into each one by one. As Eric said, septic shock is the first one. And this could be a patient with vasodilatation and then classic signs of sepsis. I don't think we're going to go into that. We've had a lot of podcasts on Rebel EM dedicated to sepsis, but that is going to be far and away your most common form of a wide pulse pressure distributive shock is septic shock. And then the next, not in any order, but let's just go through it, is neurogenic shock. This is usually a patient that comes in, possible trauma, high cervical cord injury, a loss in the sympathetic nervous system. So what that's leading to is an increase in the parasympathetic nervous system, particularly the vagal nerve is unopposed, and that could lead to bradycardia or even a normal heart rate, which should be a warning sign. That does not seem normal. Usually these patients have elevated heart rate. So in the right context, think of neurogenic shock. The next is anaphylactic shock. And then the last 2 that most people, I think, don't think about is adrenal crisis and hepatic failure. Adrenal crisis, mainly because the adrenal glands are not functioning well. So in the setting of someone who is in some kind of stressor, the adrenal glands are not able to secrete cortisol. Cortisol is very important, upregulating vascular tone, as well as a decrease in the amount of catecholamines released. So this may be a patient, if you identify them with adrenal crisis, that may need early stress dose steroids like hydrocortisone. And then the last category, which also is underappreciated, is hepatic failure. This could be your chronic decompensated cirrhotics, or it could be acute or fulminant hepatic failure. Here, there's an increase in nitric oxide synthase, which increases the amount of nitric oxide available, causing vasodilatation. So again, wide pulse pressure. Patients in this category usually feel warm to touch. They may have bounding pulses, and we call this warm shock, usually referred to as. So just to summarize this real quick, we're talking about categories of shock, which is supply-demand mismatch. We talked about the DO2 equation. We're trying to supply as much tissue oxygenated blood as we can in someone who is sick here. This is not your run-of-the-mill patient with a low blood pressure who has great perfusion. This is a sick patient, maybe elevated heart rate, increased respiratory rate, altered, decreased urine output. They feel cool to touch. And we're looking at the systolic, diastolic, but particularly the pulse pressure is guiding us. And if the pulse pressure is narrow, I want you to start thinking about, is this cardiogenic shock, hypovolemic shock, or a form of obstructive shock like a pneumothorax, tamponade, or PE? Or is this a wide pulse pressure? And then think about those 5 categories. I really don't want you to miss septic shock. So think of sepsis, 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 but also in the right context, this neurogenic, anaphylaxis, adrenal crisis, or hepatic failure. Now, as Mike was alluding to, you come to the bedside of a patient with hypotension. You're going to have a much better way of looking at this from an algorithmic standpoint, particularly paying attention to that pulse pressure.
That sounds good. I would only just tack on it. A lot of the times the narrow pulse pressure, if you do happen to have an ultrasound, that could be very handy in differentiating between the three different ones there. Maybe not as much with the wide pulse pressures, but I think that's a pretty good coverage on this topic of shock.
Well, thank you, Rebel EM listeners. That was another episode of Rebel EM. I'm your host, Frank Lodeserto. Thank you, Dr. Eric Acker and Dr. Michael Bass, and we'll see you next time.
Thank you.
Thank you.